Good morning, everyone, and welcome to Changing Healthcare Week. My name's Rich. I work for Kaleidoscope Health and Care, and you're joining us for the first event of a week-long celebration of learning from the past to help us make better decisions in the future. Learning from what's gone before to help us with a similar situation in the future. Ring any bells? Delighted to be joined for our launch event by Professor Mary Dixon-Woods. Good morning, Mary.
Morning, Richard. How are you doing?
I'm very well, thank you, Mary. How are you?
Very well.
Mary, you seem to be joining us this morning from inside a book.
You're joining me from a medieval ghost story. I thought appropriate to the season.
Mary, thank you. We've talked a bit about this before. What language do we think that is in?
I think it's Latin, but if our viewers have better ideas, I'd be very keen to hear them.
Mary, thank you very much. So we're very keen on hearing your views across this week, and we're going to start there. So, A, are we looking at some Latin? And B, if you'd like to translate any of it for us, please do. Mary, thank you very much indeed, and we're going to come and hear more from you in just a moment. But say we are going to be using menti.com this morning just to get some interaction going. And we're going to have a first question, please, on Menti, which is just we'd like for you to tell us a bit about your background, please. So using menti.com and the code 2849598, what capacity are you joining us today? With lived experience, clinician, researcher, NHS manager, other, or you could be all of those. But please do keep that screen open, menti.com, 2849598, and you'll be able to join us as we go through. We'll be a chance to ask questions and more. Lovely to see the folks already coming in. Researchers winning at the moment. Other is sort of close behind. Thank you for our lone NHS manager so far. Thank you for people doing that. To say you can also join us on Twitter all of this week. The hashtag is changing healthcare. That's all one word, hashtag changing healthcare. Please do join us on Twitter all of this week. So while people are doing that, just to say a little bit more about what this event series is. So this is an event series in partnership between Kaleidoscope and HSR UK, supported by NHS England and NHS Improvement and the Department of Health and Social Care. It is a series of events about past examples of change and how we can learn from those in terms of future progress. So you're joining us today for the launch, that's now, but we're going to be having a workshop this afternoon about learning from MRSA. We learn from the changes in day surgery tomorrow. On Wednesday, we're going to be having one of our melting pot discussions with Nigel Edwards, all about learning from the past. On Thursday, we turn to the shift in non-medical prescribing, a story of few people, actually much wealth, but much significance, before finishing on Friday with a live discussion about the future of history. So a whole range of events there, and we very much hope you can get involved. If you do follow that hashtag changing healthcare on Twitter, then you'll be able to find out all of those events for those discussions. So we are very shortly going to come to Mary for Mary's presentation. Mary, I think we just need to change it just so we can see that's a single slide. I think we just want to change that one option, and then we will come to you. So thank you again for all of those who are joining us on Menti. Thank you for those who are joining us on Twitter. And Mary, I think we're going to come to you. Mary.
Fantastic. Thank you very much, Richard. And I'm absolutely delighted to be joining you this morning. Does everything look okay in terms of being able to see the slides?
We can see both the slide and the coming up slide, Mary. So if you want to tweak that, just so that we can maintain that air of suspense. Do that. Lovely. There we go. All good. Mary, over to you.
Perfect. Great. Thank you very much. I'm going to share a very, very, very short history of trying to make change in healthcare and offer some suggestions about what I think might need to happen now. And you might be forgiven for thinking that change doesn't really happen, that we keep rediscovering the same problems. I'll suggest some of the contexts that influence or impact on trying to make change. I'll very briefly discuss some of the evidence behind quality improvement, and I'll identify what needs to happen now. I think it's fair to say that in healthcare we have had a bit of a history of what's called admiring the problems. So we've got very good at identifying problems, characterizing them, and producing data. This is a history that dates back quite a long time, but actually predates the NHS when we first started discovering unwarranted variations through the discovery of massive variations in tonsillectomy rates in the 1930s. And, 90 years later, we're still finding the same kind of problems. And possibly worse still, we're still identifying that it's pretty much the same contributors time after time. So the national audits, for example, produce very good quality evidence. Some of those audits have demonstrated good progress in making change, but very often it's the same problems being identified time after time, and difficulties in actually arresting them. We've known for pretty much ever that operational failures pervade healthcare. And by those, I mean glitches, like going to try to find a piece of equipment and it's not there, spending a lot of time hunting for keys and other essential items to get on with work. And much of this research has been done in hospitals, but more recently, my colleague Carol Sinnott has been describing exactly the same kinds of operational failures in the work of GPs. And these kinds of operational failures are extremely consequential for care because they frustrate patients and doctors and other healthcare professionals, and they make work much harder to do and increase risk and cost. We have a recurring problem of organizational degradation, sometimes at unit level, sometimes involving whole organizations. And again, you could probably write the report for the next one right now without doing any inquiry, because it's, as Kieran Walsh has shown, it's been pretty much the same story repeated every time. Very often issues of culture and behavior are implicated in these failures. They're not the only thing that goes wrong, but those issues run deep. And again, they recur over and over again. We have a big change context in which anyone trying to make change has to operate. And again, the brilliant Kieran Walsh has shown that the kind of constant, what he calls redisorganization, often happens without sufficient attention to what it means on the ground, and how that is going to result in distraction or otherwise deflect attention and resource from the business of making care better. We've obviously had no shortage of attempts to stimulate improvement through everything from pay-per performance through to regulation and inspection, the negligence system, and so on. Sometimes those policy changes make for good change. Sometimes what they end up doing is consuming an awful lot of time in more data collection that is resented by staff and doesn't really make the change. And sometimes they're experienced very negatively as simply putting staff into hot water without actually making the necessary change to improve care for patients. In the last decade or decade and a half, we've seen an increasing emphasis and a welcome emphasis on the need to do quality improvement in local organizations. Again, something with a long history. It's now over 30 years since Don Berwick started calling for as something to be implemented widely as a form of continuous improvement in healthcare. We've seen a lot of advocacy and sometimes very contentious debate about the value and merits of different QI approaches and people being taught different methods. Again, when it boils down to it, you often find that the key principles that underlie quality improvement are fairly similar. And it probably doesn't matter that much which one you choose. The correct one, the most appropriate solution is picking the right approach for the problem you're trying to solve, and having every organization absolutely has to have a systematic, structured way of solving their problems. Linked to that, I think what we haven't always been as good at as we should have been in the NHS is real clarity about what good looks like. So people are really, really clear about what they're aiming for. And this is one of the things my institute has been very keen to do. We produced recently a framework of features of safety in maternity units, which are particularly prone to this organizational degradation problem. And here what we were trying to do is offer clarity on what good looks like. And this has had an absolutely outstanding response. People have been extremely positive about it. And I think what has been good has been that emphasis on the positive. This is what we need to do. And this kind of framework can promote reflection. It's also clear, of course, that very seriously degraded units may need a very different approach to improvement. And we know this from a very good systematic review that seems to indicate that the really struggling units do have a very distinctive set of challenges that probably aren't going to be solved through one approach. I would want to emphasize that QI is just one element of good management and leadership, and I think we can forget that improvement is a big thing. It's not just one thing. It is clear that changing processes requires structured methods, skill, and resource. And we know this from the EPOC trial, which published recently and basically disappointingly showed that there wasn't improvement in mortality associated with a big QI program in surgery. We also know that different problems may need very different approaches, and local QI isn't going to solve a problem that exists on a national level, like equipment design, and needs to be sorted out nationally. I think it's also clear that we are wasting an awful lot of resource with QI that isn't coordinated and that isn't integrated in terms of process improvement design. We've got incentives that favor small individual projects rather than large-scale process design that can then be customized locally. We have issues with the kind of where the responsibility for doing this kind of design lies and how it can be coordinated. I think still too much fragmentation and separation. And I've summarized a lot of these challenges in an essay published last year in the BMJ, if people are interested to read further. So in terms of making change in the NHS, I think we have the challenge that we are inclined to keep rediscovering the same problems. Data is obviously hugely important, but on its own isn't enough. We need clear and engaging visions of what good looks like. It's absolutely essential that every organization and unit has a systematic approach to noticing operational failures and making improvement. So you have to have a QI method. I do also think how we're doing improvement right now is prone to creating waste and sometimes new risk. And I think one of my big messages is that not all improvement is about operational failures. It's to be part of a whole system approach with a focus on workforce, resources, positive working environments, culture and behaviour too. Thank you very much.
Mary, thank you very much indeed. Mary, if we were in person, we would all stand and give you a round of applause, which we can still do when we're apart. So wherever you are, Mary, thank you very much indeed. I think if anyone finds 5 minutes more condensed with wisdom than the previous 5 minutes this week, this year, I think you're doing very well. Mary, thank you so much for that. So much
pleasure. Thank you.
So much thought there, and I'm sure lots of questions people will have. Just remind you how you can ask questions. So again, we're using Menti this morning. So if you go to menti.com, 28 49 59 8. That's a good starting question. But you can enter in questions there, and would particularly ask you to think about what one question would you ask from the safety of your laptop, which you may not be tempted to ask in person. So please do put questions in. I know questions are already coming through, but Mary, I'm going to steal Chair's prerogative just for a second, if that's okay. To say, there's your point about we keep rediscovering the same problem. We see the same story come round and round. How optimistic do you feel about the future and the future of how we improve and change, given that the past does give us this bit of a sorry story about us not sufficiently learning?
Thank you, Richard. I think there are lots of grounds for optimism, actually, and the COVID story has obviously been a dreadful one in very many ways, but one of the positives that has emerged from it has been that it we can do things, we can create a collective vision. It has shown that the NHS is capable of great ingenuity, agility, and innovation, and is capable of mustering a highly effective response in the face of an existential threat. I think the other thing that's come through COVID has been this very powerful sense of values and the sense of respect that people have in the NHS for providing the best possible care for patients. I think the GP community have been one of the heroes of this whole sorry episode of COVID. That they have kept going, and they have in quite an extraordinary way continue to provide a service day in, day out, and have shown great agility and innovation in their response to it. So I think there are lots of grounds for optimism through the COVID example. The second thing is that I think there is increasingly this recognition that the data on its own is data is critical, but also not enough on its own. I think there's also grounds for optimism because we can now have some good examples of how change can be made. And I think we're also, in a funny kind of way, beginning to learn what doesn't work, and that kind of gives clarity about what we do need to do.
Mo, thank you very much. And sort of touching on COVID, there's been so much talk about changes which have been made, and I'm sure, Mo, there'll be lots of people wanting to echo your praise of the GP primary care community for everything which has gone on there. I think there's quite a lot of excitement people are seeing, Mary, about how certain changes have been accelerated. What advice would you give to people thinking about how you then sustain that sort of beyond sort of that white heat of crisis response?
Okay, that is an absolutely super question. So we're obviously responding to these massive imperatives, and I think there is a risk that people will become a bit exhausted, or that the change is just for COVID and rather than forever. So I think, and I would say this, wouldn't I? I think we need evaluation of some of these changes so we can identify what should be preserved as enduring changes that persist long past COVID. Some of the change that we've seen are probably things that should have happened long ago. And I'm thinking of things like the changes to outpatient appointments and so on. But I think we also have to be really careful. Some of the things that we've been doing in this institute has been building visions of what good looks like, given that you can't provide the service in the way you used to for vulnerable populations like people with heart failure, people who have COPD. These are characteristically populations with high need, often in less advantaged communities. And we have to be really careful we don't design systems that end up excluding or further marginalizing people in those communities. So I think that really good thinking about what good looks like and what good looks like for whom has got to be the key to keeping things going. I think also once the kind of urgency of the crisis has passed, remembering that the NHS can do this, that when you empower people and you give them this, the permission, if you like, and the sense of will, they really can do fantastic things. And I think keeping that spirit alive, even when everyone is kind of exhausted, is going to be important too.
As we sit around that campfire, sort of having the glow of what has been achieved to use for where we go next. Mary, thank you very much, and sort of a number of questions coming through on this theme. And thanks to those who've been sending it through, particularly around sort of how you go about learning from the good. And really interesting, Mary, that you sort of talked a bit about our model for learning from failure seems to be to have a sort of a high-profile inquiry or commission and dedicate lots of time to that. I'm imagining that's probably not the right model we want to use when we want to learn from the good. What sort of suggestions, Mary, do you have about how do you research learning from the good in the most sort of effective way?
I think there are ways we can mobilize what's happening, or catalyze what's happening, that we've been trying to work with through this institute. So for people who aren't familiar with the institute, we're funded by the Health Foundation, and our mission is to create an evidence base for improvement. One of the things we've been seeking to do has been to be governed by a very participatory ethos. We value the learning, the expertise that patients and staff bring to improvement. And I think if we can do that, and we can create these very positive, compelling visions of what good looks like, that are consensus built, if you like, with the communities of staff and patients, we can actually go a very long way. I'll give you one example of what we've been doing. One of the things that has always bothered me has been the waste involved in process improvement. So we have very good ways of developing clinical guidelines. Everybody knows how they are made. But once it comes to a process improvement, so trying to implement that in practice, my view is that an awful lot of the time, you can actually design that once, and then the job optimize it locally. So something like how you design a COVID safe corridor for transporting people from one bit of the hospital to another is the kind of thing you can design in principle once to local systems to do the improvement work to make it happen in their organizations. But it doesn't need everybody to design an SOP every single time. That the task is how you get it to work locally. And I think by bringing people together, you can actually consensus build these things. People can be engaged in a highly participatory way in coming up with a solution that works most of the time. And we've demonstrated this now through a process improvement for handling obstetric emergencies during COVID, which we were able to do in less than 6 weeks. So I think there are new techniques, actually, again, researchers, evaluators responding to the challenges of COVID that we can use to get some of this learning better and faster.
Lovely. Mary, thanks very much. Questions still coming through. Please do continue to put them up. Menti.com, 28 49 59 8. Mary, a couple of questions coming through about the role of sort of national bodies and sort of national policy. Some being sort of more forthright than others about where this might get in the way. But is there, you're talking a lot about sort of this balance between what needs to happen sort of once nationally, what needs to happen locally. How do you see, what's the secret to getting this relationship right, so that it's not too domineering from the top and not too everything that's left for local actors to come up with?
Okay, I think that's an interesting question, and I'm not sure I have the answer to where exactly national bodies would sit in this. I think the principle I'm advocating is that if you work with the people in the system, the patients and staff, up with really good solutions, and I can demonstrate how good those solutions can be through some of the work we've been doing over the last 6 months. I think you need honest brokers in the system, and that doesn't necessarily have to be the national body running the thing. That can be other groups who take on the job of coordinating and running these process improvements, and we have those honest brokers in the system. And then I think it's up to the national bodies to endorse and adopt these things, essentially not in the way, but also not feel they have to control everything. And indeed they can't. They don't try to. They don't control what's happening in quality improvement at the sharp end. And I'm proposing something that sits a bit above that, and that is then useful and actionable to the people trying to make the change in their day-to-day point of care practice.
Mary, thank you very much indeed. You've spoken a lot about engagement. Mary. A nice question through from Peter. Thank you, Peter, for joining. Saying, as a patient representative, are we being unrealistic in expecting more engagement, and that means sharing decisions-making process that impact directly on us? What's the role of sort of patient community engagement in the sort of processes you're talking about, Mary?
Okay, I think it's that is a terrific question. I'm really glad Peter has asked it. I think we have not got always very clear about patients and carers' role in process improvement. It seems intuitively clear to me that patients and carers are part of the solution. And one of the things we have learned is the importance of co-producing visions of what good looks like for all of those stakeholders. So, for example, I mentioned the COPD project we've been doing, and that was looking at what can be what can be provided remotely to caring for this group of people. And what we discovered is that clinicians think much of the care can be provided remotely. So of 9 things, clinicians thought most things could be provided remotely, but of those 9 things, patients thought 4 couldn't be. So if you left patients out of the picture, you don't realize that isn't something they want. Similarly, at the moment, we're looking at remote antenatal care, and we're discovering again that there isn't always consensus between professionals and women and their families about what they want. So I think they have to be involved in that. Where I think then we don't necessarily, it's just taking up patients' time, is something like designing the route for a COVID safe transfer between 2 parts of the hospital. There's no reason to involve patients in that, because this is a process that just needs to be worked out. It isn't a values-based thing. It doesn't require perspective. It's essentially an engineering problem. And then I think trying to involve people in that just becomes tokenism. So I think I'm extremely committed to the idea that we have to involve patients. It seems incontrovertible to me, but also there are things a bit like when you fly on a plane. In the days when we used to fly on planes, I don't need to be involved in the how they get the trolley onto the plane for serving my meal, but I would want to say in what kinds of things they serve me. So that is a great question, Peter, and thank you so much for asking it.
Mary, thank you very much indeed. We've talked today about face-to-face events and plane travel, both things which people may have these sort of dim and distant memories. What was that? We're very quickly running out of time, and I do want to talk a little bit about sort of what's coming up. But a very last quick question from me, Mary, if that's okay. A lot of our discussion, quite rightly, in the response to COVID, is around inequalities. We haven't really touched on it today, but I think surely a big piece of how we think about change and improvement in sort of coming months and years will be about how you can think about change with regards to inequalities. So, for your view.
You're absolutely right, Richard, and I do fear sometimes that quality improvement hasn't taken enough account of the inequalities, inclusion and diversity needs of the population. And these are questions that require a lot more attention. So I'm very glad to say that this space, which is this Institute's big event, is coming up on the 25th of November. And inclusion, diversity and inequity and equality are major themes. And we'd be delighted for anyone who's with us today to join us then. It's free, it's online, and it will be great fun.
Mary, thanks very much. And so we are going to have to close, Mary. But if people are wanting to find out more about anything you've talked about today, what's the best route?
This Institute website. So just Google that, and you will find us.
Good. You probably get better result by googling this institute rather than just googling this, I imagine.
Indeed.
Mary, thank you very much.
Thank you very much indeed. Have a great conference.
Mary, thank you. And thank you everyone for joining. We've got a couple of very quick final questions for you. Firstly, across this week, we've got a whole range of events, which hopefully you're going to be joining us at. So which of those events are you most looking forward to? This afternoon's workshop about how the NHS tackled MRSA. Tomorrow about how the NHS made day surgery the norm. Our third workshop about how nurses and HPs came to prescribe, so non-medical prescribing. Our melting pot discussion about what extent can we learn from the past, or our live discussion, which is going to be with Professor Sally Sheard and Professor Bruce Keogh on Friday about the future of history. Yes, we did just design that session so that we could use that title. Thank you for people voting on this. That final discussion, we're already getting a lot of votes. I'm sure there are lots of people looking forward to tomorrow's debate about day surgery as well. So please do continue to vote on that one. So please do join us for the rest of this week. Changing healthcare remains the hashtag. We'll give you a short evaluation Menti survey in just a second. It would be lovely to hear your thoughts. But say thanks so much for joining today. Thank you again, Mary, and we look forward to seeing you at our future events. Mary, thanks very much.
Thank you very much.
We will put up our valuation slide and we will leave it there. Thank you, everyone.